Hello, everyone. Welcome to DocTalks. I'm Dr. Manju George, the Scientific Director at Paltown Development Foundation, the nonprofit that supports Colon Town. Thank you all for joining. And today we have Dr. Tim Newhook with us. So I want to make this a little bit different than the previous times you've done this DocTalks. So I'm not going to introduce Dr. Newhook, but then we will ask him about his journey here, his personal and professional journey, and have him tell us something about his work and all the things that interest him about, ctDNA and liver resection and all of that.
Yeah, thank you so much for having me. I really appreciate the invitation, and I feel like we've had a whole new world, a whole new arena to meet so many people with social media, particularly with the pandemic. And I enjoy social media and have been following Colon Town and like to participate. So when you asked me to participate, I jumped all over it. I really appreciate the opportunity to talk about what I'm passionate about and how I think the field is moving, and also tell you a little bit about myself. So as Dr. George said, my name's Tim Newhook. I'm a surgeon here at MD Anderson in the Department of Surgical Oncology. I primarily do liver and bile duct surgery and some pancreas surgery. So I'm an HPB surgical oncologist. Having trained here at MD Anderson, I'm doing fellowships in both a 2-year fellowship in cancer surgery, surgical oncology, where you do HPB training. And then I decided I wanted more and did 1 extra year, a separate standalone liver and pancreas surgery fellowship year as well on top of that, and then joined the faculty after that. Within the HPB year as well, there's a little bit of liver transplantation training, which was something that I really wanted and absolutely augments my ability to help people with complex situations in the liver and bile ducts for sure. So as I was chatting in the very beginning, I really do feel like for me, I found the one thing in the world I'm supposed to be doing for a living, and I'm very passionate about it. And part of that comes from where my life, and Dr. George asked me to tell you a little bit about my life and how I got here. So I'm from Toronto, Ontario. I'm Canadian. I was born there. And when I was 10, we moved literally across Lake Erie. So just hopped the border across Lake Erie to where Pennsylvania touches the water, basically. Just south of the lake, and from Toronto, the big city, to a very rural area in Pennsylvania. My father was a surgeon. He was a thoracic and vascular surgeon and trained at the University of Toronto, and was working in Canada for a time, and then decided to move to the United States. And that's how we came to the United States. So my father was a well-trained surgeon. And interestingly enough, his father, so my grandfather, was a surgeon and cottage physician in Newfoundland. So all of my family is from Newfoundland, Canada, and some from Nova Scotia and the Maritimes. And in St. John's, Newfoundland, my grandfather was the regional cottage doctor. And how it was then was that each zip code, essentially, but a large region that you could get to realistically, had a doctor in a hospital that was a cottage, and he was responsible for everyone. So he had one of those, for example, he had one of those, I don't know what they're called, but the railway cars where you push it and you can go down the railway. And whenever the doctor was on the railway going out into the bush in Newfoundland, maybe to deliver a baby or something, all the trains had to stop. And that was my grandfather. And from there to my dad, then to me. And I tried my hardest throughout my life to not emulate my father. And turns out it's hard to avoid fate, I think. So I went to train in surgery after medical school in Philadelphia. I trained in surgery at the University of Virginia in Charlottesville, and had excellent training there with very strong mentors who turned me on to surgical oncology first, and did research in pancreas surgery with a mentor of mine, Todd Bauer, who's an MD Anderson graduate. And from there, I just fell in love with the art and science of surgery, as well as the art and science of taking care of patients with cancer in the liver and the pancreas. Hence, coming to MD Anderson, I was very fortunate to be chosen to come train here. It's one of the best things that ever happened to me in my life, other than my wife and kids. And from there, I told you already, stayed for training and was able to stay on faculty here. So I primarily take care of patients with liver and bile duct issues. And about 90% of what I do, I would estimate, is taking care of patients with metastatic colorectal cancer to the liver, complex situations requiring a multidisciplinary team, working very closely with my medical oncology colleagues, some of my very close mentors like Scott Kopetz, and then my liver mentors, Dr. Bote, as well as some of our colorectal surgeons. So we have a great big team that focuses on this disease all the time. And I think that that's what's required to try to get the best outcomes. So thank you for having me. I hope that was enough, short enough story about me. Something I've become very interested in my early career now is biomarkers for helping us guide treatment and make decisions about what we think could help for patients with metastatic colorectal cancer to the liver. And when I say biomarkers, I mean things that we can detect, like CEA, everyone's probably heard of that. But other things are biomarkers. Every lab that we get is technically a biomarker. Changes that we see on imaging, things like that can technically be a biomarker. But what we've used for a very long time, I felt hadn't really changed very much. Is very vague and sometimes hard to decipher. I'm more of an objective person. And when ctDNA came about, I definitely jumped on that and thought that this was the next thing. And I definitely think that this is very critical. I think it's going to transform how we take care of this disease for everyone, all stages of disease for colorectal cancer going into the next decade. And I think we're going to more and more use it to question a lot of the data that has come before, because we can definitely stratify patients in a much more precise, dynamic, and objective way. So before I click along as well, I'll preface with saying that there's not a lot out there right now in terms of good data for stage 4 resectable colorectal liver metastases and ctDNA. It's that new. Yes, there are studies, and I'll show you some of them, but there's not like a giant New England Journal of Medicine prospective randomized trial using this as of yet, but it's coming. So we're on the cusp of some big changes, I really do believe. So hopefully it's not like Bitcoin. Moving on. Oh, I pushed the wrong button, sorry. So as I said, what I do for the team that takes care of patients with metastatic colorectal cancer is something called hepatectomy. I'm sure most of you are familiar with what that term means, but what it is a liver resection, trying to remove the cancer from the liver. And for many patients, that can certainly help, and some not. And making that decision is difficult. Part of the reason why that's difficult is that many patients, most patients, upwards of 70%, will have recurrence either in the liver or in other parts of the body after curative intent liver surgery for this disease. As I said earlier, prognostication and stratifying for different treatment strategies and sequences has always been based on what I think are very vague clinical factors. And what are those factors? I'm trying to make a decision about whether a liver resection will help you based on whether your nodes were positive in your colon tumor specimen, for example, or how did the CT scan change with chemotherapy, or how deep into the colon wall did the tumor invade? What are the other things that were interesting to look at on pathology that they gave me in a pathology report? But these are all very vague. There hasn't been an objective dynamic marker outside of CEA, which also has proven to be sometimes not helpful. Measurement of the treatments that we offer, the response to them has been imprecise. As I mentioned, CEA, radiographic changes, not an absolute objective measure of cycle to cycle changes with chemotherapy, for example. There's been a giant leap forward in the last 10 to 20 years with regards to measuring the term that we call biology of a tumor, the behavior of your tumor. The word that I like to use in the clinic are the skills. The tumor has acquired what skills? How fast can it move? Where can it move? And we've learned that a lot of that is associated with certain mutations that can be sampled within the tumor itself. So what is the toolkit that an individual patient's tumor has, and what is it most likely going to end up acting like? And that can help us make some complex decisions, and I'll show you some of that in a second. But definitely more dynamic and sensitive biomarkers are needed, as I mentioned. So this is a complex slide, and we'll get back to it here in a second. There's a lot of things on it, but what I really wanted to show you is that in the red boxes is that the two most common ways of managing this disease for patients with metastatic colorectal cancer to the liver involve surgery and chemotherapy. Surgery is a local therapy. It only acts on the disease that we can see. What worries me as a surgeon, typically more than the disease that I can see in the liver, is actually the potential for disease that I cannot see. So we like to marry a local therapy, hopefully surgery if possible, but there are other local therapies like ablation, radiation, internal radiation like Y90, things like that, with something that treats your whole body, goes everywhere that blood goes, and hopefully treats the disease that we cannot see if it exists, and that's chemotherapy. So surgery followed by chemotherapy afterwards is called adjuvant therapy in the top red box. And then the other way to manage this is something called perioperative therapy, which is typically how we manage patients here at MD Anderson most of the time, is almost like a sandwich. Chemotherapy is the bread, surgery is the meat. So a little bit of chemo beforehand, surgery, and then chemotherapy afterwards. So as you can see from all of these vials of blood here, there are many opportunities to sample biomarkers in the blood to determine what's going on with the potential disease if we had a very sensitive biomarker. This figure is borrowed from a paper by Dr. Tai from PLOS Medicine in 2021. I'll show you a little bit more. It's a beautiful figure demonstrating how they did their study. And I think it really highlights the opportunity we have to get minute to minute, day to day, cycle to cycle data about this disease with this biomarker. So why do we practice perioperative therapy most of the time? So again, chemo followed by surgery by chemo. I like to think about the fact that we can assess response to therapy. If I remove your tumors and then give chemotherapy, it's truly a cleanup cruise sort of situation. I can't really ascertain what the chemotherapy is doing. Is it working? Is it changing the tumor? Things like that. So when we have that example present in the liver, for example, we can see those changes and let us know if we need to make a different treatment recommendation or whether there's been a response and it's time to go to surgery. We can determine if the tumor will respond, and the opposite of that is progression. So as you can imagine, if we're worried that there's disease that we cannot see, which often there is, or there wouldn't be such high recurrence rates, right? If we give chemotherapy and the tumors progress, then there's a good chance that after surgery, despite hepatectomy, that the disease we can't see will progress and we don't have a great drug to treat it. So you'd be wondering why we're going to the operating room, because it may not help. It also ensures that we give some chemotherapy and treat your whole body. So as you can imagine, surgery, and I'm sure you know, is not 100% perfect every single time. There can be complications. I call them speed bumps. And what those speed bumps do is slow down the car. So what that does is it can delay an opportunity to get to chemotherapy on the back end until you heal or are strong enough to receive chemotherapy. So at least we gave some before and kind of treated your whole body. Sometimes patients are stronger before surgery. That makes complete and total sense. So we're able to give stronger and sometimes more efficacious in terms of number of drugs, chemotherapies before, and then back off a little bit afterwards after a successful surgery. And then obviously it can make tumors smaller, easier and safer to remove, sometimes convert situations that are not resectable to a resectable situation. And then, as I said, my favorite reason is to treat the disease we cannot see. And the disease we cannot see, the term we use for that is occult metastatic disease. It's there, we just can't see it. And do we have a measure for that now? I think we do. So who has it? So I'll quickly talk about mutational profiling, because I think that that's very important, is really the backbone of this whole phase of biologic measurement. And it's part of our common language here at MD Anderson. We are, if we can, get some form of tissue of the tumor, either from a primary tumor or a liver metastasis, we typically send it to get complete mutational profiling, so know what mutations are present there. That's a measurement of the skills, right? It can also help us identify actionable mutations. And what I mean by that are mutations that may identify tumors that are succinctly susceptible to individual drugs or regimens, targeted therapies, things like that. There are standard of care alterations that everyone should be measured for, including RAS, BRAF, and microsatellite instability. Those can help direct care. But to be honest with you, in the general community of surgeons who take care of this disease, is that there is some skepticism of the actual clinical value of this data. Is it really going to change management? If there's a tumor in the liver and I can remove it, we should remove it. I think we're starting to question that. This is a really busy slide, but it's just to show you that actually these mutations are really important. If you think of all those pictures on the side are individual cell signaling pathways. All it is a circuit. And the end of the circuit is tumor growth. So if one of those things that are in the circuit is always on from a mutation, we're going to have uncontrolled growth. So it makes sense to measure these things to know what circuits are going haywire, so to speak. There's an increasing emphasis on this as we tailor and personalize more treatment strategies, both with local therapy and systemic therapy. So the most common one we talk about here at Anderson, and one that has really served as the backbone, is the RAS mutation. And we know that it is associated with worse outcomes. So a RAS mutation has a higher risk of early recurrence and lower survival. But we've deciphered more and more going forward that it's not necessarily just the RAS mutation alone. It's all the other members of these circuits that can contribute to change how much of the current gets to growth and differentiation. So starting with RAS, we've moved on to now a combination of both RAS and something called tumor protein 53. Together, the co-mutation is actually a more refined way to determine potential prognosis. SMAD4 we look for, APC, PIK3CA, FBXW7, word mumble jumble. But these are things that sometimes you may see in patient records or in your pathology reports. And the reason why we're looking for these things is that they're markers, biomarkers. But what we've known is that with the addition of each one of these is that RAS alone is not be all and end all. It is not sufficient to make complete treatment decisions. We need more refined markers. The other issue with this is that these are not dynamic. It's okay, your tumor has these markers. It's not an up and down. It's not a dynamic marker to let us know how things are going. So I talked about the co-mutation of RAS, and just to show you that additional mutations added on top of that in your tumor can further refine our ability to say what we think may happen. So the co-mutation is one, and then if you add 3, obviously that's more. So the circuit is on more and more and more is the best way of thinking about it. But again, like I said, we need more precise and dynamic biomarkers. So I think the future is now. So this is a schematic of what ctDNA is. And I like this picture, and I show it to patients sometimes to try to help understand what this is. There is DNA floating in your blood at all times, outside of cells, just free-floating DNA. It's sort of like the trash from our cell turnover. All day long, lining of our mouths, our GI tract, our skin, all these things are rapidly turning over. That's what we do, right? Our nails grow, we turn tissue over. And when that happens, sometimes the inside particles of cells, including DNA, gets released into the bloodstream. That's called cell-free DNA, and it's floating around. But tumor tissue is doing that too, right? So the trick is there a way to actually determine what part of this flotsam and jetsam, so to speak, in the blood is from tumor, if it's there, and decipher that, parse that out from just the normal turnover of DNA that's in our blood. So it turns out that's like literally looking for the proverbial needle in a haystack. And actually even more, a better example is it's looking for a special piece of hay in the haystack. And we're getting better and better and better at detecting this. So you can see the tumor tissue is green, and it's turning over via necrosis from treatment or apoptosis because this tumor is getting bigger, which is cell death, or is actually secreting it out itself into the bloodstream, and it has that special little marker on it denoting that it's tumor DNA. And then the DNA strands that do not have the marker is normal tissue turnover. So how can we detect the one with the marker versus not? That's the challenge of ctDNA detection. And then from there, okay, let's say we find a piece of DNA that has a special mutation in it and say, I think that that's from a tumor. There are tests that are tumor uninformed, and that's a true liquid biopsy. That's just sampling the blood and looking for mutations and saying whether or not we think that it is associated with a tumor or not. Then there are tumor-informed platforms, which are actually taking a piece of a patient's tumor, fully sequencing the DNA that's there and say, these are all the very unique mutations that are within your individual tumor, and then sampling your blood for those specific mutations that were identified. So it's a very personalized test. And there's a pretty big argument in the literature as to when to use each one of these, which one is better. As you can imagine, there's some commercial interest in pushing which one is better than the other. But in general, those are the basics of ctDNA tests. You can imagine if tumor is not available, tissue is not available, then we have to use a tumor uninformed one. That may be confusing at times. I just had a ctDNA test. Well, it could have been a blood-based one, and now we have some tissue, and it's potentially more specific. That's a conversation to have with your individual physicians. Okay, so I don't need to tell you in this audience, because I know that in Colontown there's been a lot of discussion about ctDNA and colorectal cancer, but just some quick pictures here, just to show that ctDNA in the last probably 5-6 years has proven to be associated with outcomes. It's very important in going forward with checking this for patients with all stages of colorectal cancer, because essentially detection of this ctDNA after completion of intended oncologic, so cancer treatment. So in my case, removing a tumor both in the colon and in the liver, and we don't see any cancer anywhere else, and then completing chemotherapy, that's curative intent treatment. And we hope that there's no cancer left in the body. That's when to test for ctDNA. Detection of ctDNA in the blood at that time is called minimal residual disease. And that is a term we use a lot because that detection is associated with recurrence with almost a 100% positive predictive value, which means it will occur most likely when it's detected. And it doesn't tell us when it will recur, but it will. And that's because that tumor DNA is essentially a surrogate marker for recurrence. It's the measurement of that disease we cannot see. It's finally an objective measurement of occult metastatic disease. We've never had that. So here, these are called Kaplan-Meier curves. And all they are individual patients upon a line, and the y-axis, so the one going up and down, is telling us the proportion of patients with whatever outcome it is. And in this case, for all of these, is recurrence-free survival. So how long without having a recurrence of disease after surgery? And so this is for various stages of colorectal cancer. And as you can see in the first one, this is for all stages 2, 3, and 4 from Dr. Parikh, and showing that after intended oncologic therapy, if ctDNA is detected for patients in the red line, they recur much faster than patients who do not have detection. Important to notice that with this test that they used, patients who are negative still did recur, so room for work to be done in terms of improving that sensitivity. This next panel is also stages 1 through 3, but with a different test. This first one here is tumor uninformed liquid biopsy. The second one here is tumor informed, which had higher sensitivity. And as you can see, still a separation of curves based on detection. And then finally, here in the rightmost panel, and excuse me for 1 second, I'm going to minimize this thing here so I can see it. It's covering there we go, covering the slide. This here by Dr. Tizer is for also early stage this is stage 2 and 3 colorectal cancer here, showing a separation in curves. So the bottom line is that detection of ctDNA, minimal residual disease associated with recurrence. So what about patients with stage 4 disease and tumors in the liver that we're considering surgery for? So very quickly, I wanted to touch on a recent study that was presented at ASCO this year. This is a study called CIRCULATE-Japan, which is presented by Dr. Kotaka from Japan. And this was an arm of a 3-armed study. And what that means is there's three intended studies within one clinical trial. And it included a large number of patients with all stages of colorectal cancer and looking at the ability of ctDNA to predict recurrence. And so this included stage 4 patients. So as you can see at the top, regardless of stage in the red line, having no detection of ctDNA after curative intent treatment was associated with a 97% probability of 6 months without recurrence, 93% over a year. That is very good. I mean, that's one of the flattest survival lines that I've seen in a long time. If you look at, and the patients who unfortunately had detectable ctDNA did recur. We'll come back to this. So ctDNA and colorectal liver metastases, as I said, it's novel and dynamic and very exciting. MRD we discussed and has been associated with recurrence and worse outcomes for patients with colorectal liver metastases, and we'll get to that here in a second. In a very early study performed at our institution with just a ctDNA test at any point in time after hepatectomy, so even up to 2 years, that having detected ctDNA resulted in a worse 2-year survival. So the good news is no detection resulted in a 100% 2-year survival versus 70% for those detected. So cancer is recurring. And what we don't really know this much, and there's only been small studies as of now, is what the significance also of ctDNA dynamics. So the ups and downs, the clearance, the recurrence of ctDNA, how that has impact on outcomes after liver resection. So I want to talk about some pros and cons. Some cons of ctDNA in this setting is that most of these studies are retrospective. They're from small cohorts, a lot of times single institutions, and I'll show you some of those. There's a hesitance to integrate into routine care. Is this just another biomarker, just like CEA? Does it really change management? And is there going to be data to show that we should change management with it? There's concerns that it is expensive or may get more expensive. The repeated testing can be expensive, I guess. Again, it's another test. It's not like we're not getting other tests and replacing it with a ctDNA. It's now another added test, more blood to be sent. And personally, this is something I'm very concerned about, and we haven't done research into this yet, but I think it's pretty anxiety provoking. Everyone's very excited about ctDNA, as am I, but it's kind of like a very black and white thing. It's either positive or negative. So when you're waiting for your results, it's got to be very anxiety provoking to wonder whether or not this is going to be positive or not, similar to the scanxiety phenomenon that a lot of my patients and I talk about. What are the pros? As I said, if tissue is unavailable and you have a liquid biopsy, it can help detect mutations that can help direct care by showing you that there's an actionable mutation that has a specific drug that can help. It's a surrogate for recurrence. It's detectable up to, in some studies, a year before actual clinical recurrence, before we can see it on a scan, for example. And that can be very helpful because what we don't know yet, but is a good hypothesis, is can we give chemotherapy or something like that way early and maybe clear that, knock it out while it's very small? Time will tell. It may be a dynamic response to therapy, so we can measure efficacy of drugs and with changes in the concentration of these things. And as I said, it's finally an objective measure of occult disease. Yay, that's fantastic. And then last and very important pro for ctDNA is it's becoming more and more an entry point for patients onto clinical trials. So the status of ctDNA is more and more being an inclusion criteria to clinical trials to help patients find and try novel therapies that may actually help them clear their disease. So again, this must be very confusing, and guess what? It is. It's confusing to providers. There's many different testing platforms available. As I said, there's tumor informed, tumor uninformed, this and that, this company, that company. One hospital uses one, another hospital uses another. It's out of control. And then what is also confusing is when to test. Some platforms want a certain amount of time after surgery, and how often we should test is very confusing. I think a lot of this is also, and this is a personal opinion, is that a lot of this is made much more confusing by the fact that, and I'm sure a lot of you on this line know, that there's seemingly a lack of standardized treatment paradigm for patients with liver metastases across institutions. There are very high profile hospitals, cancer centers, what have you around the world who take a very different approach to this disease. And that's because we all have our own data. And honestly, it's very good at all different institutions. And so it's hard to change, and everyone's waiting for someone to give them that data to make them change. Maybe we'll have that with ctDNA. And as I said, it's anxiety provoking. Recurrence is worrisome, but this is a public service announcement. This does not mean that recurrence is unable to be treated. There are many different types of recurrence. There's solitary recurrence that we are happy to continue to help with. And as you can imagine, there's a whole spectrum. So yes, it's worrisome, but that doesn't mean it's over. It just means we need to look and watch much closer because we want to catch it. Okay, so some quick data about ctDNA and colorectal liver metastases. So this is a nice paper from Japan. Dr. Kobayashi presented this in Annals of Surgical Oncology last year. It's a single center retrospective study, so obviously has some bias. There's some statistical things that we cannot control for in retrospective studies. That's different from a clinical trial, which is prospective, and that's good gold standard data. This is kind of a report of their experience. 40 patients who had solitary colorectal liver metastases. So what I mean by that is one tumor. And this was blood that was sampled for ctDNA before surgery. A very important point in this paper, and why this paper is informative, is because in Japan, giving chemotherapy before surgery is not standard of care. Almost everybody proceeds to surgery if resectable. So this is kind of a as-is measurement of ctDNA and prognosis. Interestingly enough, 80% of patients, so most patients had detectable ctDNA with this platform. And that makes sense, I think, because there's present disease and it's metastatic. So almost a target-rich environment for that special DNA marker in that picture that I showed you. So as I said, few receive preoperative therapy. And their main data to show is on the right here, which is again, these survival curves to show that detection of ctDNA in the blood before surgery in the absence of chemotherapy is associated with outcomes. So the way of thinking about it, in my opinion, is that if you don't have detectable ctDNA with a very sensitive platform before surgery, we're dealing with a very favorable biology, a tumor that's not rapidly turning over, things like that, that might increase the amount of ctDNA in the blood. This is a situation that's favorable. It makes me feel much better about offering curative intent treatments and having that discussion with patients. In their study, recurrence-free survival was just about a year if ctDNA was detected. So most patients recurred within a year compared to patients who did not have ctDNA detected. The median, so the 50th percentile of people recurring was not reached. So 50% of patients never recurred ever if they were negative before surgery. So they also mentioned that overall survival, so length of life, is likely longer if not detected. So again, because it's a measure of in my opinion, the biology of the tumor. This is another nice study from Dr. Tai and Dr. Gibbs from Australia, recently presented. It was a prospective study, so better data statistically from 10 hospitals in Australia, as I mentioned, and they were able to analyze both before and after surgery ctDNA, and then also samples serially, so over time after surgery. And that is the nice figure I showed you at the very beginning of the study. included 54 patients. About half of them received chemotherapy, and almost everybody received chemotherapy after surgery. The reason why I tell you that is because it's important to note that getting chemotherapy and then checking a ctDNA, if it's negative, I can't tell you with complete certainty whether you would have been positive before chemo. So we have to look at that when interpreting data, as I can't say that people are always negative, like negative before surgery, negative after surgery if they got chemo, because I don't know whether it was detectable before chemo. But that's still a good sign, because responding to chemo and clearing ctDNA indicates another favorable measurement of what we're dealing with, if that makes sense. 85% of patients had ctDNA that was detectable prior to any treatment, and 24% had detectable ctDNA after surgery. So with good surgery and good perioperative management, only about a quarter of patients had minimal residual disease. And I think that's a very good tribute to the progress we're making with this disease, that with stage 4 disease, we're eliminating, for 75% of patients, eliminating even molecularly detectable disease. So here's that nice figure again that's very confusing. Some patients had surgery followed by chemo. Some patients had the sandwich approach, like I mentioned. And as you can see, each one of these blood vials, as they checked blood many, many times, and were able to follow it serially. This is a busy slide, but there's only a couple things I want to show you because I like these figures. The 2 survival curves on the left here are just to show that their test worked. Detection was associated with outcomes. Non-detection was associated with better outcomes, even for this metastatic disease cohort. But this figure is my favorite and what I wanted to show you. Each one of these lines represents a patient. So this is the first time point after surgery. 70% of patients did not have any detectable ctDNA after surgery, and 30% did. The majority of patients, regardless of treatment that they're in the cohort, who had no detectable ctDNA after hepatectomy, continued to have non-detectable ctDNA all through the course of their care. So that's a testament to both the favorable biology, but also the fact that with this test, as we get more sensitive, we can say with much more certainty that without detection, your chance of recurrence is very low. And then so they use that to conclude that serial sampling may actually be able to reflect treatment efficacy, that patients who did not have ctDNA detection postoperatively had a low risk for recurrence. That's important for later. And I quote here in their discussion that they are taking the next step from this in their thoughts, that patients who do not have ctDNA detection after hepatectomy for this disease would likely experience low or very minimal impact of shortening or omitting the post-operative chemotherapy aspect of their care. Because the question is, what are we actually treating if we can't even measure molecular disease? There's no data to say that if you have one cancer cell in your body that chemo is going to cure that. We don't know yet. But if we have a very good measure of occult disease, it's my feeling that we're not going to get much out of that other than more side effects. So I circled this in yellow for you because that's what I want you to take away from the slide, is that as these platforms get more and more sensitive, we can say with more certainty that you're not going to recur. So what have we found quickly with our data? It's retrospective, but I've been fortunate to work with an excellent team and publish some of our data recently. We did a prospective study, which was recently published in the Annals of Surgery, which we enrolled patients over a long time period with an early ctDNA platform for patients who underwent curative intent liver surgery. So at the end of their surgery, they had no visible disease in their body. And we had paired ctDNA sampling before surgery and after surgery. And we wanted to prospectively evaluate dynamic changes after hepatectomy. Here's some more survival curves just to show you that in this study, because most patients had ctDNA, had preoperative chemotherapy, that detection of ctDNA before surgery was not associated with outcomes. And that's because I'm not completely sure that we have any way of saying whether the source of the ctDNA is actually all we see. And if we remove it all, of course, it's not going to be associated with outcomes because we removed it. But detection of ctDNA after surgery was associated with both recurrence-free and overall survival. So our approach using this data allows us to prognosticate effectively. One of my favorite contributions from this data is to show, though, is that the dynamic measurement, so before and after surgery measurement of ctDNA, actually allows us to identify not just two populations, positive and negative, but actually three. So patients who did not have detectable ctDNA before surgery and did not have it detected again after surgery had the best outcomes. But interestingly, if you had detectable ctDNA before surgery and then negative after surgery, you had the same outcomes as those who didn't have it detected the whole time. And that's very, very, very good outcome, because it doesn't mean that before surgery that's just the data that you need. We need both, because we identified a population of patients who had molecular clearance after surgery. So that's why I think that the detection after is the most important data time point for entry into trials and use it for treatment sequencing. So again, back to the CIRCULATE-Japan data from ASCO 2022, just to show you a similar phenomena using ctDNA dynamics. As you can see, these different colors correspond to these populations of patients up here. And instead of surgery this time, this is in patients who had chemotherapy after surgery. So they had their tumors removed and they were either negative or positive, and then got chemotherapy. And then after chemotherapy, most got chemotherapy, but after that, whether they were positive or negative, so the sandwich around chemotherapy dictated outcomes. And patients who were negative the whole time in black did the best, but patients who had their ctDNA cleared by chemotherapy, so had molecular clearance by systemic therapy, experienced the same outcomes. And the reason why I put that on there is to show you that regardless of the intervention, whether it's surgery or chemotherapy or ablation or radiation, that actually the dynamic changes in ctDNA can actually prognosticate. So the next study we did was to ask who is at higher risk of having detectable ctDNA after surgery, having minimal residual disease. It's hard to say, because again, are we going to use our vague clinical factors to say who's at highest risk? It'd be nice to know before undergoing a really large operation with a lot of risks that we think there's a good chance that you may have residual disease left over and recur early, right? So because pre-hepatectomy ctDNA does not necessarily mean it'll be detectable after surgery. And as we know, patients who have it cleared by surgery have similar outcomes. So more and more sensitive platforms are needed. Can this direct care? So we looked at a cohort of 105 patients who had ctDNA sampled within 180 days of surgery and looked for factors that were associated with having ctDNA detection, as I said, within 180 days. And 30% of patients had ctDNA detected within 30 days. So you see that number kind of jives with all of the other studies, the proportion of patients who had minimal residual disease. In an impressive number that I took away from this, that is in that experience of patients, that the median overall survival for this disease, a stage 4 disease for all comers, whether they're positive or negative, was 80 months. That's very high compared to a lot of other stage 4 solid tumors. So we're making a lot of progress. But the interesting fact to show here is that the median recurrence-free survival, so how long it took for 50% of patients to recur, was only 8 months. And I think that's important to show because, again, recurrence doesn't mean it's over. It means we need to catch it early, and there are options. So what we found is that having multiple tumors in the liver, obviously, is associated with having detection of ctDNA after surgery. That just is a marker of the burden of disease that's there. But also, interestingly enough, co-mutation of RAS and TP53. So those are the mutations in the tumor. I'm trying to tie it back to the beginning of the talk, was associated with having ctDNA detection. Almost 50% of patients with that mutation status had minimal residual disease, because that is a marker of the skills that I told you about in the beginning, a marker of having potential for occult metastatic disease. The next bullet I just wanted to show you is that patients who had detection or not detection had similar rates of lymph nodes that were positive in their primary tumor, had the same tumor viability in their primary tumor. So just to show you that this biomarker is much more precise than the vague clinical factors we've always used. And the co-mutation of RAS and T53 was the only independent, so the only standalone marker that predicted detection of ctDNA within 180 days of surgery. So to tie it all together, postoperative ctDNA detection is associated with outcomes. The positive predictive value is near 100% for recurrence if detected, but that doesn't mean that we can't do something about it. It just means we need to pay attention. In certain mutational analyses can identify cohorts of patients who are at a high risk for having it detected, and it's really just a measure of risk for occult metastatic disease. I personally really feel that there's a complementary impact for both tumor somatic mutational profiling as well as circulating mutational profiling. And at Anderson, we routinely obtain both for all of our patients with this disease. So the last thing I want to talk about is, can ctDNA direct our care? Sorry. In one of those studies that I showed you from Annals of Surgery, the providers did not know the results of the ctDNA. It was a blinded study done at the end. So they didn't use ctDNA to make treatment decisions. And as I told you, patients who had ctDNA detected had recurrence faster, as well as a shorter recurrence-free survival, and overall survival. And those who had no detection had much better outcomes. But interestingly enough, the figure below shows you the proportion of patients who got different types of treatment. And what I want to highlight to you is that in that study, less than half of patients who ended up with no ctDNA detection got chemotherapy. So providers are trying to use the data that we have to say, your risk for recurrence is lower or low or zero. I don't think we should continue with chemo. It's not worth it. And so we're starving for a better objective measure of that. And turns out that it just kind of fell that way with ctDNA anyway. So if we were to use ctDNA to direct care, would it be much more precise? So quickly, this is a good time to just rehash quickly the multidisciplinary management of resectable colorectal liver metastases. As I said, liver resection with chemotherapy, either surrounding surgery or after surgery, is the standard care of treatment. So perioperative or adjuvant therapy. There have been several randomized clinical trials to show that both of these strategies are effective at prolonging time to recurrence, but none of them have proven to impact overall survival. So the jury's still out on whether or not chemotherapy really actually works. Also, in all those trials, almost none of them have used a biologic stratification to allocate treatment. It's all been all comers. So it'd be interesting to take those trials and get a blood sample from all those patients and measure their ctDNA to see if the chemotherapies worked for those who are positive and not for those who are negative, for example. As I said, the rationale for chemotherapy is mainly to treat occult disease for those who have resectable disease, so treating the disease we cannot see. But wouldn't it be nice if we had an objective measure of occult disease, right? We just talked about that. Oh, sorry. So this is just another slide from CIRCULATE-Japan. I obviously very much liked this presentation that showed that patients who had high-risk disease, who did not have, sorry, the thing is blocking my screen here. So in stage 2 and 3, so keep in mind, this is not patients with colorectal liver mets. This is stage 2 and 3 colorectal cancer, but I want you to think of the concept. Patients who are ctDNA negative 1 month after surgery, who got chemotherapy, had no difference in outcomes from those who did not get chemotherapy. So chemotherapy did not help patients who did not have detectable ctDNA. So I think that implicates this test to say, if it's not detectable, what is chemotherapy really doing? Just hurting, I think. So that led us to think about designing a clinical trial here to evaluate this for patients with stage 4 disease, because as I showed you, there are patients who even after surgery, we can molecularly clear with surgery. So if we do a good job of stratifying, we may be able to determine patients who have the best chance of low recurrence and maybe change how we treat them. So the aim was to determine if ctDNA after liver resection for colorectal liver metastases can stratify our patients into high and low risk groups for recurrence, and that may inform the postoperative part of chemotherapy. We hypothesized that patients who did not have detectable ctDNA after surgery would have a longer time to recurrence, if at all, regardless of what chemotherapy or any chemotherapy that they got after surgery. And a lot of this is derived from the lack of survival data with any strategy, as I mentioned in other clinical trials. So the question is, if ctDNA is negative after hepatectomy, can we de-escalate the postoperative portion to either a lesser drug or none at all? And this is the advent of risk-stratified adjuvant surgery rather than a one-size-fits-all. And the primary endpoint of this study is 12-month recurrence-free survival in the cohort of patients who are ctDNA negative. So the inclusion criteria for this trial are quite open, because the idea is to stimulate a discussion amongst our team about whether this is an appropriate situation to risk stratify postoperative chemotherapy. So over 18 years of age, undergoing resection of colorectal liver metastases with curative intent. So obviously not other sites of extrahepatic disease that wouldn't necessarily be curative intent. And the primary colorectal cancer, so the colon or the rectal tumor, must have been previously removed or being removed at the same time. So we want to leave the OR cancer-free, if that makes sense. And then patients must have received at least 4 cycles of chemotherapy beforehand. That's because in our treatment paradigm, we're not yet ready to abandon the chemotherapy before surgery aspect for all the reasons that I mentioned before. Exclusion criteria is obviously if the primary tumors remains in place. That's because of if you're positive, I don't know if that's from your primary tumor or occult disease. Postoperative therapy is not planned, or patients unable to continue with chemotherapy, or having other active malignancies which might interfere with the ctDNA test. So here's the schema. Patients who come to see us with resectable colorectal liver metastases undergo preoperative chemotherapy, are deemed a surgical candidate for curative intent surgery, and we offer the study and enroll. We also, and that's when we send, we first collect a sample of blood right before surgery, go to the operating room and remove the tumor, and we're using the Signatera assay by Natera in this study, which is a tumor-informed study. The tumor leaves the pathology unit within a couple of days after they're done evaluating it, goes straight to Natera, and they make the platform coupled with the preoperative blood. And then at 1 month after surgery, we check another ctDNA as a landmark time point. And whether that is positive or negative just dictates whether patients continue with their intensive chemotherapy. So if you got FOLFOX before, if you're positive, you get FOLFOX afterwards, up to the provider. If you're negative, the initial chemotherapy regimen must be de-escalated. So either Xeloda alone or 5-FU or surveillance, also up to the provider. We didn't want to dictate in this trial exactly what patients get. We want it to be a discussion and determine whether ctDNA-directed postoperative chemotherapy is a viable clinical option. And then we check serially every 3 to 4 months, ctDNA along the way, and all the way up to 12 months, the provider team can do whatever they want with regards to that data. So if you're negative in the beginning and you go on to surveillance, but now it ends up flipping positive at 3 months, don't despair. We're allowed to start chemotherapy then. If you're positive on chemotherapy, positive and you go on to chemotherapy and after 3 months, it's negative, the option is to stop or de-escalate. We really just wanted to validate our day-to-day real-life pragmatic care using ctDNA direction. So what do we expect to find, or hope to find, I guess, is that patients who have ctDNA detection will have, who do not have ctDNA detection will have similar or better time to recurrence as historical controls, better recurrence-free survival than those who have ctDNA detection despite receiving stronger chemotherapy, and that a larger proportion of patients in that cohort will remain ctDNA negative at 12 months as compared to those who are ctDNA positive. We expect to find that postoperative chemotherapy can actually be guided by ctDNA detection safely. And then through survey data, I hope and I think we'll find that patients who de-escalate chemotherapy or undergo surveillance have an improved quality of life and less adverse symptoms from cumulative toxicity of chemotherapy compared to those who have ctDNA detection. And then I think this would be the advent of risk-stratified ctDNA-guided treatment for patients at our institution. So in conclusion, we need more precise and dynamic biomarkers for patients with this disease. Is it here with ctDNA? I think so. I think a lot of the people in the community think so as well, but we're still waiting for that big prospective trial. Detection of ctDNA after curative intent hepatectomy is associated with worse outcomes. But conversely, those who do not have detection are associated with better outcomes and may actually recur at all. Dynamic changes in ctDNA detection perioperatively, I think, refines prognostication. We've at least shown that retrospectively and may direct treatment decisions going forward, and we're evaluating that now prospectively. And what I do think personally is that if you don't have ctDNA detection after surgery, there's no clinically evident disease, you had curative intent surgery, I do think that it's safe to de-escalate chemotherapy or undergo surveillance because I think it's definitely a risk-benefit discussion, but I think the risk of recurrence is low compared to the amount of cumulative side effects and toxicities of chemotherapy. I've never had chemotherapy, but I know and have been told by my patients that it is something to be avoided if you can. So thank you very much for your time. I know a lot of that was my personal thoughts and where I think it's going, but it is a very nascent field and very exciting times to be a liver surgeon who takes care of patients with this disease. Thank you very much.
Okay, Dr. Newhook, that was excellent.
Yes,
so we'll go from the top. What would happen if you do liver surgery, get chemo, and after chemo, the scan shows new liver mets?
So recurrence after hepatectomy is the question?
Yeah,
it
and
depends.
chemo.
We very often start the sequence all over again. It depends on when it recurred and what type of recurrence it is, you know, how much tumor there is, where it's located, what surgery you had before, so how much volume of liver left. It's an extremely complicated situation, but the number one thing I would say is that you still should be seen by a liver surgeon because we've published from our institution series of patients who've undergone 2, 3, 4 liver surgeries in sequence. And even at some point in time, those patients can be cured because as long as there's a salvageable recurrence where we can act on it in some way, as you can imagine, at some point in time, you may stop recurring. Or at the very least, multiple interventions from surgery can be better in terms of mileage than chemotherapy alone, as long as it's safe.
So the next question is, can you talk about the significance of the number value of the ctDNA test? Does a higher number on this test indicate cancer will come back more, or, you know, does it mean anything?
So I think you're talking about the variant allele fraction. So the percentage number next to it, and it varies by test. It's almost like a concentration, right? Like a concentration of something in solution is a way of thinking about it. I think the jury is still out on that, and there hasn't, at least in this disease, colorectal liver metastases, there isn't any data to show that the amount that's detectable correlates with outcomes. Do I think that it's coming to that? I do, because I do think that at least changes in it is indicative of treatment response as well as tumor burden, but we don't have that yet. I can tell you that contrary to what I just said, in the study from Dr. Tai in Australia, they had a small proportion of patients in that cohort where they were able to ask that question, and it was not associated with outcomes. But again, it was a very small group, so statistically, you just can't say it. I think the jury's still out.
Okay. The next question is, what if you have a bad mutation, but your ctDNA negative? So can you ignore the badness of the mutation you have, because the fact that you are ctDNA negative is a good thing, right? How does that
is
compare?
A very good thing. That's a great question, and that's a very good thing. So having a bad mutation in your tumor, again, as I said, one mutation alone is clearly not sufficient. It's more of a pattern. So the additional mutations that are measured, it's just evidence that tells us what skills your tumor may have. But again, you could have the worst tumor in the world, but if it was completely removed and didn't have the opportunity to travel yet, it's gone. And that's what we're hoping ctDNA can tell us, is actually objectively measuring disease we cannot see. So I would say with the negative ctDNA at that point in time, regardless of bad mutations, that you are cancer-free. But what we do is patients with more deleterious mutations like that, we tailor our surveillance a little differently.
Okay, thank you very much. So the next question is, patient had 3 resectable liver mets. They were removed, and then pre-op positive ctDNA and post-op ctDNA negative, and has been negative for 7 times. Can you make a prognostic comment? The patient has an HAI pump and wants it removed. What would you suggest?
That's a hard question. So so let me just recap: preoperative ctDNA positive, postoperative negative ×7, resected all visible disease and has a pump in place, not being used. I don't know, but yeah. If there, obviously it depends on how long. Like if you checked 7 times in the course of 7 months, that's different than 7 times over the course of 2 years and it's been negative. I would say your chance of recurrence is low. Personally, that's my general feeling. We know the data at least points to this being a very favorable situation. Again, it depends on what tests they're using, sensitivity, things like that. I don't know exactly what it is, but I would say that's very favorable. And I think it's a very good conversation to have to remove the pump if that's what they would like, and if that's feasible and safe with their surgeon. We don't place pumps here. That's a whole nother talk, whole nother doc talk. So I don't want to make the direct comment on that. I would speak with your surgeon.
Okay, I think I'll go to the last question here. It's basically about the concept of minimal residual disease between early stage cancer versus late stage cancer. How relatable is it?
Yeah, it's a very good question. If I'm understanding the question correctly, I think what it boils down to is, if there is is there an occult disease out there we cannot see? Question number 1. But also, how much is there out there? There is a threshold of detection even for these tests. So there's a true negative, like there is no cancer there. We know it. If we had a crystal ball and we were looking at it, there's truly negative. But there's also a proportion of patients who will have such low volume occult disease that the ctDNA is going to be negative, but may eventually recur, right? And I do think that probably where some of the clinical data that we look at daily helps us is in that question, right? So stage 2 disease negative after complete removal probably feels a little bit better about being negative than someone who had the largest liver resection possible and has some indeterminate lung nodules and things like that and is ctDNA negative. Does that make sense? So there is a little bit more to this than just positive, negative. You have to interpret it. But when you hold all those things constant in like a statistical model, ctDNA is the most powerful predictor.
Okay. This is the last one. I think we are at 12:05. So,
no problem.
So somebody had a Signatera value of 30 before hepatectomy, and afterwards it was 0.09, but positive. So, does it matter, or all that matters is that it is positive?
Personally, I think at this point in time, all that matters is that it's positive, unfortunately. And that's because these tests, that's a tumor-informed test that is made from that person's individual tumor and is extremely specific. I don't work for Natera and I never made their plate, but from what I understand is that they try to avoid using the really common mutations. So like RAS might not even be on their Signatera because it's found in so many other tumors. They're looking for like the fingerprints of your tumor, right? So it's detectable, but very, very low. And that's an extremely sensitive test, which is why it's positive. It may have been negative on a less sensitive test. But the fact that it's low, if this person got it checked after surgery and has yet to undergo chemo, I would recommend chemotherapy, because that may be a situation where the clot can at least be turned back very far or cleared completely by something like adjuvant chemotherapy.
Okay. So thank you very much. I think I don't want to delay you any further.
No, my pleasure. I know I talked a long time. I'm sorry. Thank you so much.
No worries. Yeah, this was very informative. And thanks to everyone for joining. The video will be available on Paltown University. Thank you to everyone.
Thank you so much for having me. Take care.
Okay, take care. Bye.
Bye-bye.